Dr. Bardia, it's so nice to be here with you today to discuss what I think is a very interesting topic because it has been in flux over the last few years, really taking center stage. And that is the evolution of HER2 positivity and how that definition has changed over time and how it really has treatment implications that have allowed us to treat our patients with greater specificity and more effectively. Now, can you tell us a little bit about how that definition has changed in metastatic hormone receptor positive breast cancer?
Absolutely. I think the HER2 has been one of the biggest success stories, not just in breast oncology, but oncology in general. And gosh, this dates to more than 30 years ago with the advent of HER2 oncogene discovery, with the identification that HER2 gene amplification occurs in a subset of breast cancer, and that's associated with worse prognosis. And that is something that can be targeted with trastuzumab. So for clinical development of trastuzumab, we needed a companion diagnostic. And Dr. Slayman and Dr. Press and the group, they came up with IHC to look at the HER2 expression or the overexpression of HER2. And it was felt that IHC 3+ would be complete membrane staining in more than 10% of cells. And that's a good biomarker for a subset of patients that would have a response to trastuzumab. But then there was this big 2+ group as well, where you would have close to complete membrane staining in more than 10% of cells. And the idea was some of these tumors are driven by HER2 oncogene. So they added the FISH as well, where you can look at HER2 gene amplification. And so if you have HER2 IHC 2+ with HER2 gene amplification or HER2 IHC 3+, that was called HER2 positive. So that's been the traditional definition for years, HER2 positive, where by looking at IHC, if the tumor is IHC 3+ or 2+ with FISH amplification, it's considered HER2 positive. Then if you call something positive, then what's the counterpart? That's negative. And so we started calling the other subgroup HER2 negative, but it does not necessarily mean that there's no HER2 expression, because HER2 negative tumors also have HER2 expression. It's lower, it's 1+ or 2+ without gene amplification, but it's still some HER2 expression.
And so now, there is the traditional HER2 positive breast cancer, and the tests were developed to pick out HER2 positive. But now we have this category, HER2 low, and now even more recent, HER2 ultralow. And it seems like things are moving from HER2 positive, HER2 low, ultralow. That encompasses what, 95% of patients who have breast cancer, their tumors. So my question to you is, do you think that it matters, these subcategories will matter eventually?
So even in HER2 IHC 0, there is some HER2 expression, and there are about 30 to 40,000 HER2 receptors per cell, even in tumors that are IHC 0. So 0 does not mean that there is no HER2, it's just that by IHC we cannot detect it. But for an ADC like trastuzumab deruxtecan, all you need is the receptor to be present. And if the receptor is present, the ADC would bind to it, get internalized, release the payload. So biologically, I feel that for luminal cancers, trastuzumab deruxtecan works across the HER2 spectrum, even in tumors that are IHC 0 from an immunohistochemistry perspective. Then there's a practical answer. If you look at the FDA label of trastuzumab deruxtecan, that's for HER2 ultralow and HER2 low. So for insurance reasons, we are stuck with finding a tumor that has some HER2 expression. So that can either be low and ultralow. And just to build on this, what is low and ultralow? Low and ultralow essentially refers to the HER2 expression. So low would be low HER2 expression, which is HER2 IHC 1+ or 2+ without FISH amplification, and HER2 ultralow is what we call 0+, which means some HER2 staining, but less than 10% of tumor cells. So if there are 2 or 5% of tumor cells having some HER2 expression, that would be considered HER2 ultralow. And so the original HER2 positive essentially is HER2 high expression. HER2 high expression is HER2 positive, and then HER2 low expression, and then ultra low expression.
And do you find that it's Now with these categorizations, we know that it has practical implication, right? Because it affects eligibility for therapy. But do you think that our pathologists, across the board, not just at major academic institutions, but in the community, are aware of this? And I believe that there was an update, or at least a caveat to the ASCO-CAP guidelines in 2023 that are giving some guidance on designating tumors as HER2 low and ultra-low. But do you think that has trickled down into the community enough? And what do we need to do so that our pathologists are more aware of why it's important?
HER2 ultra-low is not being routinely reported. Pathologists are starting to report HER2 low, so IHC 2 plus versus 1 plus, but they're just still calling HER2 IHC 0, which includes ultra-low because that's 0 plus. So we need more education so pathologists are aware that this is something that's actionable. You just cannot say HER2 IHC 0. You have to further quantify whether it's 0 plus versus 0, 0 or HER2 null. Some institutions, some academic institutions the pathologists have said they would just report the percentage of cells that are HER2 positive. So rather than get into low, ultra low, they would just say 5% of cells were HER2 positive. So then, you would know that this is ultra low and you can use appropriate therapy.
So we first, I think, heard about HER2 low, or at least I did, with DESTINY-Breast04. And seeing that data for the first time was very impactful. And right there, I think it really made a splash because it shifted this paradigm of how we think of HER2-directed therapies. I remember being very surprised that in the DESTINY-Breast06 trial, I think the number was very high, about 60% of tumors that were locally scored HER2 0 actually fell into the category of HER2 ultra-low and even HER2 low, some of those. So that, I think, underscores how there is the potential to miss patients that would be, in that DB06 group and eligible now for therapy with T-DXd.
In a way, it simplifies things because now as long as you have some HER2, you don't have to necessarily distinguish between ultra low and low. You can use T-DXd. So it does simplify because there can be some difference in terms of whether a slide is HER2 low versus ultra low, difference among pathologists. So this does simplify things.
What do you think about, and tell us a little bit about that evolution of first even deciding to try to use this HER2-directed ADC in a population that was not HER2 positive?
Yeah. So as a reminder, DESTINY-Breast04 was for patients with HER2 low metastatic breast cancer who had received at least one prior line of chemotherapy and showed that T-DXd was superior to standard chemotherapy, both in terms of progression-free survival and overall survival. And that was a practice-changing study presented at ASCO in a plenary session. And after that, we started using the HER2 low terminology and started using T-DXd. And DESTINY-Breast06 was different from 04 in that it did not require prior line of chemotherapy, also included HER2 ultra low, so it was a broader patient population, and that's why the comparator was T-DXd versus chemotherapy with capecitabine or paclitaxel. In terms of the results, we saw this at ASCO. There was a special session where DESTINY-Breast06 was presented, that there was improvement in progression-free survival, median PFS, 13 months, more than 13 months, which besides CDK4/6 inhibitor is the only other drug that's shown a PFS of more than 12 months in the metastatic setting. So definitely clinically meaningful from a patient perspective, but it's also given IV while capecitabine is given oral, and we can discuss in terms of therapy selection. The outcomes are very similar in HER2 low and ultra low, and just highlights that as long as there's some HER2 present, these drugs, these ADCs work. The response rate was pretty much identical, and even median PFS between HER2 low and ultra low with T-DXd.
So some of the most exciting data that I've seen presented, and it seems, with the presentations with T-DXd, each one is just a home run after home run, right? We're going with the baseball metaphor here. Yeah, so brain mets, really important because at least especially in our patients with HER2 positive breast cancer, I think we all have patients who have good disease control in the body, and then it's brain mets after brain mets, and they keep popping up. And so we have data from Destiny Breast 12, right, which now gives us some information in terms of how effective T-DXd is with brain mets. So can you speak to that?
Yeah, and I was thinking about your metaphor. So T-DXd essentially has hit the ball out of the park, if you will, in terms of what we saw with brain mets. I was very impressed with the data. So this was the Destiny trial. They looked at T-DXd in patients with brain mets. It also included patients with HER2 low disease, was not only HER2 positive. And traditionally for HER2 positive, we've been leaning towards tucatinib as a preferred regimen. But to see the response rate with T-DXd, that was practice changing. So I essentially have switched to T-DXd for patients with brain mets, not only for HER2 positive disease, but also patients with HER2 low disease, given the activity that we've seen with the drug. The question is, how does it work? It's a bulky molecule, but looks like patients who have brain mets likely have a leaky blood-brain barrier, which allows the ADC to reach the tumor, or maybe it's the payload that can reach the tumor, but it does have activity. So that's my preferred to-go medication in this setting.
Right. That also changed how I practice as well. And so I typically use T-DXd for patients with brain mets. It is interesting how we've always talked about, of course, if you have brain mets, you have a disrupted blood-brain barrier. But our traditional chemotherapy just hasn't worked very well with that, right? So it's just you need a more effective agent where whatever it is, payload delivery, in concentrations or at doses that are also tolerable to be able to cross that threshold and take advantage of that.
So it's good to have this option. It's now FDA approved for patients with metastatic hormone receptor positive breast cancer, and you can use it after endocrine-based therapy. So if I look at my treatment paradigm, usually in the first line setting, I use endocrine therapy plus a CDK4/6 inhibitor. In the second line setting, get genotyping, and then based on genotyping, another endocrine-based therapy. Maybe sometimes use endocrine-based therapy third line as well, but sometimes after second line, then move to chemo. And when we think of chemo, that's when we think of ADCs, and that's why I tend to consider T-DXd. But I'm curious about your practice as well.
Yeah, so for the most part, I try to use endocrine backbone with targeted therapies first, second, third line, and then move on to chemo. And I completely agree with you. At the time where I'm contemplating chemo, that is when an ADC, such as T-DXd, now with the data that we have in that first line setting, I would use that. But there are situations in which I don't think it's appropriate to exhaust endocrine therapy after endocrine therapy, and that's when we see a patient who is clearly endocrine resistant. This is the patient, and she doesn't come along that much, but with, say, who is on an adjuvant CDK inhibitor with endocrine therapy for a short period of time and has a recurrence while on that therapy. And then potentially you will use endocrine therapy again, if appropriate, with a PIK3CA targeted agent and maybe even another CDK inhibitor. But at that time, after progression on that, I'm not trying to find additional lines of endocrine therapy. If someone has declared, or if their cancer has declared itself as endocrine resistant, I think that it's appropriate to then move on to chemo, and then we can substitute chemo with a more effective therapy in ADC like T-DXd.
Yeah, that makes sense. It's interesting you say that. I recently saw a patient exactly this who was on endocrine therapy plus a CDK4/6 inhibitor in the adjuvant setting and had disease progression on adjuvant CDK4/6. And so in the metastatic setting, the question was, what next? Right. And if it's chemo, then I would use an ADC.
Right. And I think that you presented the subgroup analysis at SABCS this past year about basically time to progression on prior therapy and that analysis of how T-DXd performed in those populations. And I found that data to be very compelling because even in these populations where you would think that their disease was very aggressive, they did quite well with T-DXd.
Yeah, that's exactly correct. So DESTINY-Breast06 did allow patients who had rapid progression on first-line regimen, or like the patient we were talking about, someone who's on adjuvant therapy with the CDK4/6 inhibitor and then has recurrence in the first 2 years. So that was allowed, plus patients if they had disease progression in the first 6 months of endocrine plus CDK4/6 inhibitor in the metastatic setting. And when we use endocrine therapy plus CDK4/6 in the metastatic setting, generally we expect 2.5, 3 years in terms of an average, and that's why we use these drugs. But there's a subset of patients who have rapid progression on endocrine plus a CDK4/6 inhibitor. So in that setting, I'm concerned that this patient has endocrine resistant disease, maybe primary endocrine resistance. So I would consider a chemo, and that's where T-DXd can be considered. And now we have data from DESTINY-Breast06 that in that subgroup, the benefit was maintained with T-DXd over standard chemo, including capecitabine, and the hazard ratio was less than 0.4. So it was pretty effective in that subgroup. So clinically, I would feel very comfortable using it.
And then the flip side to that, so we're talking about patients who have very aggressive therapy. I thought it was equally interesting, the analysis based on number of metastatic sites, right? So as a measure of disease burden, because we tend to think of, okay, we're gonna use our big guns, our ADCs for the more aggressive disease, but if somebody has maybe lighter disease, it might not be as useful, but that's not what the data you presented showed.
That's correct. We looked at disease burden, visceral, non-visceral mets, number of metastatic sites, more than 3, less than 3. In all the subgroups, the benefit with T-DXd was maintained. So it does work regardless of the amount of disease, and that's why it's an option to consider for all patients.
Right. So are there patients then for whom you do, knowing we have this data, where you would still give them capecitabine? Who is that patient?
It's a patient-centered discussion. Right. Here and there, we do encounter patients, someone who's on endocrine therapy for, say, second, third line, or someone who's been on endocrine therapy, if you just count the duration of 5, 6 years, those patients are sometimes hesitant to move to an IV-based therapy, and they would prefer an oral option. So that's where capecitabine potentially could be considered, with the idea that I can use T-DXd after that. If I'm looking for a response, if I'm looking for rapid disease control, then T-DXd is the drug, because we know that the response rate with T-DXd is much, much higher than standard chemo.
Another endpoint, also from the same presentation, which I thought was very interesting and is interesting now across trials, is PFS2, right? And so one of the things I've been thinking about is, in what ways does PFS2 matter? I think it gives us some insight into telling us about cross-resistance of subsequent therapies, but it also gives us information on the order of therapies. A perfect study, I don't know if you agree, would have complete crossover to answer the question of whether or not the order matters. I believe in DB06, it was something like around 20%. So what do you think PFS2 in that study, as it's reported, should tell us, practicing oncologists, about how to use the data and how to apply it to our patients?
So PFS2 does, as you rightly said, give insight on how a patient does on the next therapy. So if someone gets T-DXd and then after that gets oral capecitabine, looking at how they did on oral capecitabine or the next line of therapy is very valuable. And we saw that that is maintained. So it tells us there's no cross-resistance. There's also not major overlapping toxicity, because sometimes biologically there might not be resistance, but if someone gets on a therapy that has similar side effects, they just might have difficulty tolerating the next drug. But we didn't see that. So it just gives you more assurance that you can use the other drug after T-DXd.
most of our patients probably fall somewhere in the middle, right? So what do you think is the current standard of care for those patients?
So for patients who don't have a lot of disease and not too little either, somewhere in the middle, if you look at efficacy, the data would support T-DXd because a majority of patients, as in Destiny Breast 06, you would expect that T-DXd would be better than standard of care. And these are patients where you can then use oral capecitabine or other agents after T-DXd.
One thing, though, I'm thinking of a patient that I have who is older. She is in her late 70s. She had pretty aggressive disease progression and also has some slightly low EF, right? 35% or so. But she was very symptomatic from her breast cancer. And so we decided, with the blessing of and cooperation of her cardiologist, to put her on T-DXd. Her EF has not dropped, and she feels better. So I think something that is occasionally lost in our conversation with patients is that if you are very symptomatic from your disease, that a treatment that reduces disease burden may make you feel better.
Absolutely, absolutely. The best palliation is an effective treatment, no question. It's interesting you bring that up because traditionally that patient would not be considered for T-DXd, but you have to weigh risk benefits. So then working with a cardio-oncologist like you did, I think got that patient access to a drug and is feeling better.
So a lot of what we've talked about is very inside baseball, right? We know the language we use, progression-free survival, overall survival, and sometimes when I'm speaking with my patients, I realize I just see they glaze over, and then I think about how do I frame this conversation in a way that they understand, that is meaningful, and that they can participate in. So how do you present the data you presented to the patient so that you can have that conversation and make that joint decision?
Absolutely. You have to present the data in a language that the patient understands. I'm very traditional. I usually have a sheet of paper and a pen, and I first start with a diagram in terms of what an ADC is. If I'm going to talk about T-DXd, draw the diagram, explain how an antibody drug conjugate works and why potentially it could control the disease or control breast cancer. Then I start talking about, what our goal of therapy is to prolong survival and to improve your quality of life. And with survival, we've seen T-DXd outperform standard of care. Then I talk about quality of life. And what we've seen with T-DXd, I talk about potential side effects in terms of nausea, in terms of monitoring counts, the hair loss, and then the rare but serious toxicity of pneumonitis. So I tell them that we'll monitor you very closely. If you have any shortness of breath, any cough, let us know, because that could be a sign of lung damage from this drug. And then at the end, again, I emphasize, we will be with you. Just because we're prescribing the drug doesn't mean it'll stop. We will be monitoring things closely, and we might need to adjust. At any given point of time, we make the best decision. And 2 months from now, 4 months from now, we might need to change things. So it just gives them assurance that this is not it. It's not like this is the final contract. It's just that you would be with them throughout their journey.
Right, absolutely. That is so well put. And I also use that this is not a contract, right? Because patients believe sometimes that when they are making a decision that it is the last decision, and we all have to be able to change and adapt.
Absolutely.
You spoke about, of course, speaking with the patient about the potential side effects that they may have, notably pneumonitis. How do you monitor for pneumonitis? Do you have a very specific cadence of chest CTs? Do you always work with a pulmonologist? Do you always do pulmonary function tests? Just how do you do it? Or does it depend on the patient and their risk factors?
Absolutely. It does depend on the patient and the risk factors in terms of someone who has known pulmonary disease, history of pulmonary disease versus no history at all. I generally don't get pulmonary function tests, but I do look at the oxygen saturation or the SpO2. If that's less than 92% in meta-analysis, that was a risk factor for pneumonitis. So if I do see it's closer to 92%, that's a patient I would monitor really, really closely. Not that I would not use T-DXd, but I would be very, very careful in terms of use of this drug. So that's one screening factor to consider. The other is the kidney function. That's another risk factor for pneumonitis.
In terms of the day-to-day, my experience with T-DXd, the biggest challenge is to manage the nausea. I think that we've gotten some guidance on how to manage the nausea, primarily with olanzapine, and for me, it's been a game changer, right? So do you give your patients, do you start them cycle 1 with olanzapine?
Absolutely, absolutely. So as you said, it's a great medication for breakthrough nausea, and also something to take on day 2, day 3. For some reason, works very well with trastuzumab deruxtecan and other ADCs as well. I found it to be effective with sacituzumab govitecan as well. Dato-DXd generally does not cause much nausea comparatively, but olanzapine is a good medication. The other strategy I consider for nausea with T-DXd is to use a 3-drug antiemetic regimen as primary prophylaxis. And if a patient is doing well, then I can go down to 2-drug, but I start with 3-drug. But here and there, you have patients, despite all of this, they just have bad nausea. And then you have to reduce the dose, and that often helps.
Right, absolutely. And then what about one adverse event that we see reported in trials all the time, which I have a lot of difficulty interpreting when looking at trial data without personal experience, is alopecia. Right? The grading for one is very confusing, right? Just grade 1 and grade 2. But to just really get a sense of what the alopecia is, I think you need clinical experience. So we spoke a little bit about sequencing therapies and what goes into making those decisions on how we sequence therapy. We know that there is some attrition, right? Not everybody makes it to their 2nd or 3rd or 4th line therapy. So how does that impact your decisions on sequencing?
It is an important factor, and that's why I often consider T-DXd as first line, because my concern is someone might not make it to the 2nd line. You can have the argument of, why don't you start with oral capecitabine and then you can use T-DXd next line, but what if you're not able to make the 2nd line? Then I would feel really bad that I was not able to give access to a very effective drug to the patient, because we know that with every line of therapy, there's a certain attrition. And in general, in oncology, we used our best drugs as early as possible. That's the general philosophy.
So there's clearly been a lot of progress in the field, primarily with ADCs. Right? It's all about ADCs. And there are other ADCs in development. And so what are you looking forward to? Are there any in particular, any data sets that you think might be just around the corner that we might be able to integrate into our practices?
Absolutely. These ADCs are moving into earlier lines, first line, even localized breast cancer. So at ASCO 2025, I'm looking forward. Hopefully we'll see results from some of these ADCs. We've at least seen press release that DESTINY-Breast09, which looked at T-DXd as first-line therapy against chemotherapy plus trastuzumab pertuzumab for patients with metastatic HER2 positive breast cancer, was a positive trial. We've also seen press release that ASCENT-04, which looked at sacituzumab govitecan plus pembro versus chemo pembro first-line metastatic TNBC, is a positive study. These drugs are also moving into early breast cancer. DESTINY-Breast05 is looking at patients with residual disease. We also have T-DXd as neoadjuvant therapy. So I'm looking forward to these pivotal trials where these effective agents have moved to first line or localized breast cancer. How about you, Dr. Callahan?
Right. So, it's very exciting to think about DESTINY-Breast09, because we've been treating HER2 positive first line breast cancer with taxane, trastuzumab, pertuzumab for a long time, right? That's been going on for a long time. So I don't think that it's any surprise that T-DXd may be better. Where I think things will get really interesting is in deciding whether to put someone on that forever. Because we all have patients who are on first-line taxane, trastuzumab, pertuzumab, and have been on the antibodies for years, living a very good, very normal life. And we have data from Patina that tells us in those patients that are estrogen positive and HER2 positive, we could, during the maintenance phase, add a CDK inhibitor that is very well tolerated to endocrine therapy along with the dual antibodies. And they do very, very well for several years. So I am also looking forward to trials in the future that take T-DXd for a period of time and then potentially, switch to dual antibodies to figure out how do we not only have the most effective therapy possible, but also take into consideration the quality of life in patients who are going to have multi-year survival.